When we talk about somatic symptom disorders, these are mental disorders that manifest as physical symptoms. So the problem is in the brain, but they manifest in the body. And these suggest illness or injury. This is very common in young, low socioeconomic status females. This is usually what you get in a case. A young woman who's of low socioeconomic background who have symptoms that cannot be explained by anything that is medical. It is not a medical condition. And the management for these patients, we will talk about several types, including somatic symptom disorder, conversion disorder, illness anxiety disorder, somatoform pain disorder, and body dysmorphic disorder, and finally, malingering and factitious disorders. So let's take a look at these. The management is you need this patient to be with a single identified physician, and the physician must have brief, regular monthly visits. So once the patient is diagnosed as being somatic symptom disorder, you need to make sure that you avoid any diagnostic testing and specialist referral. So they will be like, I went to this many doctors and they couldn't find anything wrong with me. And the way you treat these patients is you have brief, regular monthly visits with the patient. And you need to reassure the patient that serious illness has been ruled out. This is the main goal of this. You should never try to say that your symptoms are fake, you are faking it. You need to legitimize the symptoms, but try to make functional improvement. Because the problems in psychiatry is it affects the functioning, okay, in most diseases, but in somatic symptom disorder, it's going to affect the person's functioning. The person will be in and out of hospitals, won't be able to manage a job properly, and the person will be stressed. And once you establish a strong physician-patient relationship, you can go for a mental health referral. Now, first we will talk about somatic symptom disorder. This is when you have one or more unexplained symptoms with excess thoughts, anxiety, and behaviors in response to the symptoms, which is of at least 6 months of duration. There should be a history of multiple hospital visits with repeated testing, and those tests must come back negative. So these patients will have negative tests, and yet they say they have pain in the abdomen. And this is most commonly seen when there's a history of childhood abuse or adult sexual trauma. They want to stay in the hospital. This is unconscious, and they want to stay in the hospital to gain treatment. Now, before we go into conversion disorder, it's important to understand two things. It's called symptom production and symptom motivation. So, symptom production is the production of symptoms. Is the person aware of producing the symptoms, or is the person unaware of producing the symptoms? If the person is aware, they could be doing things like eating glass. If the person is unaware, it could be the brain doing it for the person. If symptom motivation is conscious, that means the person knows that he is making up the symptoms, compared to does not know why those symptoms are manifesting, why he is doing it. We will talk about this for each of these. In conversion disorder, they have unconscious symptom production and unconscious symptom motivation. What this means is the person doesn't know that this is a psychological issue, is not producing the symptoms on purpose. So let's take an example. We'll take an example of a cook in a school. The cook knowingly uses expiring ingredients and ends up poisoning kids. Some kids die, and the cook who also ate the same food is sent to the hospital paralyzed. Now, when the cook, now we have a stress here. There's some sort of stress on the cook. The poisoning of the kids is the stress here, and this has led to the paralysis. So when you do the physical examination and lab workups, these are all negative, and the diagnosis is said to be conversion disorder. What you need to understand is the person is actually paralyzed. The mind has paralyzed that limb. So even if you start a fire in front of the patient will not be able to use that arm or whatever limb that was paralyzed to get away from the fire. The mind knows that there's some sort of conflict, and there's a primary gain. By being paralyzed, it will reduce the stress. And the secondary gain is for the person, because there will be a lot of sympathy, that the benefits of being sick. And usually these symptoms manifest if the person has already seen someone who is paralyzed, who is actually paralyzed from another disease. They will know how to manifest the symptoms. They will not be doing it consciously, but the brain knows. You should look for something called the labile indifference. Usually when you are diagnosed as being paralyzed, there's obviously going to be some significant distress. But these patients will not have any sort of distress. This is a sign which is usually seen in these patients. And this manifests in muscles or sensory organs. The treatment for this is psychotherapy. Next, we have illness anxiety disorder. It was used to called hypochondriasis, but now it's called illness anxiety disorder. This is what you will get in questions. And again, in this case, you need to have at least 6 months of duration of different symptoms. Now, usually medical students will also have this. After they learn topics such as pathology, they will think, okay, even the psychiatry lecture, most of you might be thinking, okay, I have this. But then these thoughts would disappear in a few days. You are not going to be worried about it. You are not going to be anxious about it. These people will be anxious about this disease, and there will be a lot of preoccupation about this. Like, you learn this disease, you think you have it, but you won't be going to the hospital about it. These patients will actually go to the hospital. You tell them there's nothing wrong, but they will not accept that. And there's something important: do not give these patients placebos. They will figure it out sooner or later. The main goal is psychotherapy, and it's important to develop a relationship with the patient. Next, there's somatoform pain disorder. The symptom here is pain, severe prolonged pain, and again there's a primary gain and a secondary gain. We will talk about these again. So in this case, there's pain. Now it's important to know, if the person has fever, then you cannot call these any sort of a somatoform symptom disorder, because you can't manifest fever. But pain can be manifested by the mind. And in this case, we have a 20-year-old woman who was hit by a ball 3 months ago. She was taken to the hospital, where workup was obtained and no fractures were found. She was prescribed acetaminophen for several days, but had no relief from the medication. Before the accident, she was demoted recently and was unable to start the new job, even after being examined by several doctors. So there was some sort of a stress. The primary gain, that's going to be the secondary gain. Because of this So the person was demoted, and the brain will manifest this as pain in an attempt to get some sort of a secondary gain, such as, okay, you can have more money, attention, etc. And always you need to rule out any medical conditions. After that only you can classify a person as somatoform. And again, the treatment here is psychotherapy, because they are not doing it on purpose. Their motivation is unconscious, but they do have these symptoms. They think they do. Next is body dysmorphic disorder. We have a 20-year-old medical student who's taken to the psychiatrist by her boyfriend. He claims that she keeps saying that she has a hideously large nose and she wants to do surgery to correct it. She no longer leaves the house for social activities. She has been using dangerous chemicals to sculpt her nose. The physician notices that the nose is unremarkable. There's nothing wrong with the nose, but the person is fixated on something being wrong with the nose. And it's most commonly facial flaws. Remember Michael Jackson? He would always wear that mask, and these people would avoid social situations. So whenever Michael Jackson would go out for some social situation, he would be wearing that mask. So these patients would go on doing a lot of surgeries to correct whatever they perceive as a flaw. And they would keep doing it, and until it actually becomes abnormal. And if you, as a doctor, continues this unnecessary surgery without treating this underlying problem, this is considered a medical malpractice. The treatment is psychotherapy, and SSRIs can be given if needed. The reason we give these patients an SSRI is because this is a type of OCD. They are obsessed with their appearance, and as a compulsion they would go on doing surgeries, and this is said to be related to serotonin neurotransmitter, serotonin, sorry. So the treatment for this is an SSRI. Next, we have something called malingering. This is for personal gain. Symptoms are consciously manifested. Motivation is also conscious. This is usually when, think of a person who's seeking drugs. So it's just a con. And it's not a psychiatric syndrome. There's nothing wrong with them, except that they're trying to cheat you in trying to get some sort of reward, such as drugs or money, something. Symptoms are intentional, motivation is intentional. This is for a specific external gain. But when you consider factitious disorders, so malingering is consciously done. Factitious disorder is when the symptoms are consciously manifested, but the motivation is unconscious. So let me copy these. Let me write this. Symptoms consciously. Motivation unconsciously. So what this means is they would consciously make up the symptoms. I will give an example. But the motivation behind this, the reason why they are doing it, they have no idea. Usually there's a history of, let's say, abuse as a child or hospitalization as a child in these patients. So one way that these patients would manifest symptoms is, let's say they are asked to take a urine sample. They would go to the washroom, and after filling urine, they would injure themselves to get some blood and mix it with the urine. or they would eat glass. These are very common case studies. They would eat glass to induce bloody stool. So the reason why they do it, they don't know. There's some sort of a primary gain. The brain needs that for some sort of a primary gain. It's usually manifested as medical attention and sympathy. And sometimes they do it by proxy. They do it to another person, usually a mother to a child. So the mother would asphyxiate the child. The mother would come to the hospital, say the child has apnea, difficulty breathing. And when the person is tested in the hospital, there is going to be nothing wrong. But when the person is given a monitor to test at home, the mother would, let's say, put a pillow up the child's face so that the person can't breathe, inducing apnea episodes. They don't know why they do it, but they do it. This is why they would do it by proxy. They want to get attention through someone else. They know they're doing it, but they don't know why. Now, let's compare the three. Somatoform disorders, the physical examination and workup is negative. So, let's take that example of the cook. The paralyzed arm. When you do examinations, there's nothing wrong. The mind doesn't know it's producing these symptoms. The person doesn't know that he or she is producing the symptoms, but the brain is producing those symptoms, and there is unconscious motivation. In factitious disorder, there's obviously going to be something wrong in the physical examination and workup because they are consciously producing that, but they don't know why they're doing it. They just know they need some gain. Meldinging, it's for gain. They are making up symptoms, and the motivation is also made up. They're usually looking for drugs. Now, we have a 48-year-old woman who comes to the clinic due to ongoing abdominal pain, general weakness, decreased appetite, and dizziness. She says the pain is ruining her life and is worried that her previous physicians may have missed something. Over the past several years, the patient has been hospitalized 3 times with similar symptoms. No etiology for the pain has been identified despite extensive workups. The patient is concerned as the non-prescription analgesics she takes are ineffective. Physical examinations, vital signs, and lab tests are all normal. Which of the following is the most appropriate step in the management of this patient? So this is a typical case of somatic symptom disorder. And what you need to know is, you need to schedule regular outpatient visits. You bring the patient in for visits, establish a proper patient-doctor relationship, and make sure that you do not prescribe unnecessary tests. Next, we have a 20-year-old man who comes to the ER due to abdominal pain that is 10 out of 10 in severity. The patient says he was hospitalized for similar symptoms 3 times in 2 years and a diagnosis was never found. He does not approve access to his previous medical records. On physical examination, lab workups, heart, lungs, all are normal. Abdomen is soft, non-tender with normal bowel sounds. But the patient moans throughout the examination. At the end of the examination, the patient asks for a letter of excuse from attending an exam so that he can recover at home. Which of the following additional feature is most likely present in this patient? Feelings of hopelessness? No. This is malingering. He's definitely creating a con here to gain a letter so that he can not sit that exam. Excess anxiety about the physical symptoms. The moment he leaves the hospital, those symptoms are gone. Refusal of invasive medical examinations. Yes, he will not agree to do a colonoscopy or any sort of invasive medical examination. And since this is a con, there is going to be no suicide ideations or attempts. Next, we have a 38-year-old woman who comes to the office with multiple scratches, sores, and abscesses in his legs. She is worried that the sores and abscesses have not healed. The patient has no idea how the sores developed, and she had a similar presentation 3 years ago. The patient required prolonged hospitalization and IV antibiotics to treat the sores 3 years ago. Which of the following is the most likely cause of this patient's condition? Let's rule out the answers from the bottom, and then I will explain this case. It is not bipolar disorder. There is no mood elevation or depression. Malingering is not the answer because she is not looking for some gain. Body dysmorphic disorder. No, there is an actual symptoms which is seen by the physician. Somatic symptom disorder. This is when there are no symptoms and there is no motivation behind it. Factitious disorder. Let's take a look. And finally, conversion disorder. Now, conversion disorder means there has to be a stress which will lead to paralysis of the limbs or sensory impairment. This is a typical case of factitious disorder. Why do I say that? Because these are all self-induced. One way you can induce abscesses in your body is by injecting feces under the skin. And the reason behind them doing that is unknown for the patient. They are doing it themselves, but they don't know why they are doing it. This is a typical factitious disorder patient. Next, we have a 32-year-old woman who comes to the office for follow-up. She was seen a month earlier for evaluation of a year-long history of fatigue and leg pain. The patient describes feeling tired all the time and a sensation of heaviness and aching in both legs, unrelated to exertion. Lab tests and other examinations are all normal. She says, my other doctor also said that my tests show nothing abnormal. During her 20s, she received supportive counseling for 3 months after being raped. The patient does not smoke. She drinks 1 to 2 glasses of wine and smokes marijuana on most evenings to relax after work. Family history is significant for bipolar disorder in her maternal grandmother. Vital signs are stable and physical examination is unremarkable. Which of the following historical risk factors is most consistent with this patient's diagnosis? First of all, what is the diagnosis here? This is a typical case of somatoform disorder. Now, I talked about 2 associations of somatic symptom disorders. One is a history of sexual trauma. The other one is a history of childhood abuse. A 45-year-old woman comes to the emergency department with sudden right leg weakness. The patient's husband of 20 years recently died suddenly in a car accident in which she was driving. He has a stress. Neurological examination shows normal muscle tone, normal deep tendon reflexes, and no Babinski sign in the extremities. However, the patient cannot lift her right leg off the bed while supine and is very worried that something is wrong. She is able to stand without assistance from a sitting position, and her gait is without abnormalities. Which of the following is the most likely diagnosis? This is a typical case of conversion disorder. There was some sort of a stress which led to psychomotor paralysis or sensory paralysis.